Every psychiatrist has a story about that patient, the one who made them reconsider their career choice during sleepless nights. If you don't have that story yet, congratulations. Your number hasn't come up yet, but statistically it will. Maybe once every 5 years, maybe less, but when it does, you'll know. And what I'm about to tell you might save you from learning the hard way what the rest of us had to learn the hard way. I want to talk about a very specific kind of clinical encounter, not the patient who's difficult because he is sick, not that patient who is uncooperative because they are frightened, not even the patient who throws a chair, although we'll touch on that. I want to talk about the patient who is dangerous to your practice the way nitroglycerin is dangerous to a postal worker, that oily liquid that can detonate if you so much as sneeze in its general direction. These patients are rare, genuinely rare, which is precisely what makes them so dangerous. You don't develop a pattern recognition for something you encounter twice a decade. By the time you realize what you are dealing with, you are already 3 months into a therapeutic relationship that has quietly metastasized into something very difficult to manage. So let's build that profile. Let's talk about what to look for, why it matters, and what your options actually are once you have identified the situation. The first feature, and arguably the most important one to recognize, is paranoia. Now let's be precise about what we mean. Paranoia is not delusion. It sits about 2/3 of the way along the spectrum toward delusion. But it hasn't crossed that line. A delusion is a fixed false belief held with absolute conviction and resistant to contradictory evidence. Paranoia is suspicion, not conviction. It is more rigid than a regular opinion, certainly. You can't talk someone out of it with a well-placed observation the way you might redirect an anxious thought, but it doesn't have the ironclad, immovable quality of a full delusion either. It lives in that treacherous middle ground where the patient is just rational enough that you can't dismiss what they are saying, but just distorted enough that engaging with it pulls you into a quicksand. And there is a critical distinction. Paranoia tends to be thematic. It's almost always about one thing. Somebody is out to get them. Somebody has an agenda. Somebody is hiding something. Whereas delusional states can sprawl across an enormous range of content, like grandiose, erotomanic, somatic, jealous, persecutory, mixed. Paranoia, though, drills down into one tunnel and stays there. In the clinical setting, this manifests as a persistent, corrosive suspicion that everything you do has a secondary agenda concealed behind the obvious one. You prescribe a medication because you are getting kickbacks from the pharmaceutical company. You recommend therapy because you want to bill more sessions. You set a boundary because you don't actually care about them and want to get rid of them. They might say this to your face, or they might not. Sometimes it's communicated through behavior. For example, a certain look, a loaded pause, a comment about how they understand how these things really work. They want you to know that they know the truth. And they want you to feel the weight of being watched by someone who isn't fooled. This is destabilizing, even for an experienced clinician, because the accusation, however unfounded, creates a self-consciousness in the room that distorts the clinical encounter. You start second-guessing yourself. You start over-documenting. You start choosing words with the caution of a diplomat negotiating a hostage release. And the vigilance is exhausting. The second feature is verbal ability. These patients are almost, without exception, extraordinarily articulate. They can speak without interruption, without repetition, and without losing the thread of their argument for an hour straight, possibly longer. But none of us will ever find out, because no clinician is going to let a session run past 60 minutes when 5 other patients are in the waiting room developing their own pathology from the frustration of waiting. This verbal fluency is not incidental. It's a weapon. The ability to sustain a coherent elaborate, emotionally modulated monologue for that length of time gives the patient an enormous advantage in any clinical encounter because it means they can control the session. They can filibuster, they can redirect, they can bury a critical piece of information inside 45 minutes of tangential narrative so that you don't even register it until you're reviewing your notes that evening. Don't confuse this with the pressured speech of mania. That's disorganized flight of ideas, topic jumping. This is the opposite. This is a controlled, purposeful, rhetorical, sophisticated speech. These patients could argue a case before the Supreme Court if they had the credentials. They don't, but they have something almost as effective. An audience of one who is professionally obligated to sit there and listen. The third feature is leverage identification. Those patients have an almost uncanny ability to identify your pressure points, your buttons, your vulnerabilities, and they are organized enough to use that information systematically. This is not a random lashing out of someone in emotional distress. This is targeted. They will insinuate that you are incompetent, that you are a bumbler, a quack, that it is a small miracle you are ever permitted to practice medicine. They will question your training. They will reference a study you haven't read that supposedly contradicts your approach. They will compare you unfavorably to their previous psychiatrist, who was apparently a genius but unfortunately moved out of state. Or they will take the regulatory route. They will mention almost casually that they know how to file a complaint with the medical board, that they've done it before, that they understand the process. This is said not as a threat exactly, they're too sophisticated for that, but as information, just so you know. Just so the power dynamic in the room is properly calibrated. Or they will go for the moral jugular. You don't actually care about patient. You are in this for the money. You are just another cog in a broken healthcare machine that chews people up and spits them out. And there is the most important part. They calibrate this pressure with extraordinary precision. They bring the therapeutic relationship to the edge of rupture, right to the brink of the point where any reasonable clinician would say, this is over. I am terminating the treatment. But they will pull back every single time, just enough, just before you reach for the discharge paperwork. They soften, they apologize, partially they express vulnerability, they remind you that they are suffering, which they are, and you find yourself drawn back into the process, back to trying to unravel a knot that was never designed to be unraveled, a Gordian knot that exists specifically to create the illusion that resolution is possible if you just give it a little more time, a little more patience, a little more effort. Alexander the Great solved the Gordian knot by cutting it in half with a sword. That option is available to you too. It's called discharge from treatment, but we'll get to why that's more complicated than it sounds. The fourth feature is extensive involvement with institutional authorities. These patients have a relationship with bureaucratic and legal systems that goes well beyond what you'd expect from an ordinary citizen. They are frequently entangled in minor legal disputes, not major felonies. Those would involve a different personality profile and a different set of problems. These are minor, chronic, revolving door encounters with the legal and administrative apparatus. They are in a dispute with Medicaid about coverage. They are appealing a Social Security determination. They are filing a complaint against an unemployment office. They are pursuing some kind of action against a former employer who had the misfortune of hiring them. Each of these disputes individually might be entirely legitimate. Some of them probably are. But the pattern, the sheer volume and relentlessness of institutional combat tells you something important about the person sitting across from you. It tells you that they are practiced in navigating adversarial systems. They know how complaints work. They know how appeals work. They know how to generate paperwork, meet deadlines, and sustain pressure over months or years. And that skill set is fully transferable to the doctor-patient relationship. The fifth feature is economic precariousness. combined with a demonstrated willingness to pursue legal remedies. They are typically not wealthy, and they have a track record, verifiable, documented, of suing or threatening to sue for damages arising from relatively trivial provocations. They know how to use small claims court. They know how to file complaints with licensing boards, with facility administrators, with anyone in a position of authority over someone who has annoyed them. This combination, limited financial resources and high litigious energy, is particularly dangerous for clinicians because it means the patient has very little to lose from initiating a legal action, and you have quite a lot to lose from defending against one. Even a completely unfounded allegation consumes time. It consumes mental energy. It consumes money, both in legal fees and in lost revenue while you are dealing with the fallout. You win the case, but you still lose because you've spent 6 months thinking about it instead of treating patients. The sixth feature, and this is the one that makes the entire situation genuinely tragic and genuinely difficult from an ethical standpoint, is that these patients are not just difficult characters, they are sick. Usually there are real psychiatric problems sitting alongside the personality pathology. Generalized anxiety disorder, major depressive disorder, sometimes substance use problems as well. These are legitimate conditions that cause legitimate suffering and that deserve legitimate treatment. And here is the bind. Refusing to treat this kind of patient is problematic, not just ethically problematic, although it is that too. Practically problematic because very often by the time this patient arrives in your office, they have a long track record of having been refused treatment by numerous clinicians who are exasperated by their behaviors, who were concerned about getting dragged into protracted disputes, who looked at the risk-benefit calculation and decided it wasn't worth it. And each refusal reinforces the patient's paranoia. Each time a doctor says, "I can't treat you," the patient files it as evidence that the system is rigged against them, which, from their perspective, it increasingly is. So you are caught, treat them, and risk a clinical and legal complication that we have been discussing, refuse to treat them, and add to a pattern of rejection that arguably makes their condition worse, while potentially exposing yourself to allegations of patient's abandonment. Let's talk about what actually goes wrong in the clinical management of these patients, because the personality dynamic are only half of the problem. The other half is pharmaceutical. These patients tend to push relentlessly, intelligently, persuasively for medication regimens that deviate from standard practice. This takes several forms. First, there is a demand for frequent medication changes. Nothing works. Everything causes side effects. Every drug needs to be switched after 2 weeks because it's clearly not helping. This creates a pattern in the medical record that looks to any reviewer like chaotic prescribing. And it is chaotic prescribing, but the chaos was engineered by the patient, not the clinician. Good luck explaining the distinction to a medical board reviewer who's looking at 30 medication changes in 18 months. Second, there is a dosage problem. Either too little medication because the patient refuses to take a therapeutic dose, or insist on a homeopathic quantity that can't possibly be effective, or too much medication because they demand escalating doses under the justification that they don't feel well. This is particularly dangerous with controlled substances, where the patient engages in what I'd call soft misuse. Not the classic pattern of running out early, not the doctor shopping pattern that prescription monitoring programs are designed to catch. Something more subtle. A relentless incremental ratcheting upward of dosages, always accompanied by a plausible clinical justification. It's not working at this dose. I'm still anxious. The pain is still there. Each individual request seems reasonable. The trajectory, viewed from above, is alarming. Finally, these patients do their homework. They scour the internet for studies, case reports, guidelines, anything that might support their preferred medication strategy, and they present this information with a pseudoscientific fluency that can be surprisingly convincing if you are not paying close attention. They will cite an obscure case report from a Scandinavian journal suggesting that their requested medication combination has been successfully used in treatment-resistant cases. They will invoke the concept of clinical judgment and the art of medicine. They will frame their request as bold but defensible, unorthodox perhaps, but well within the range of options that a creative, patient-centered psychiatrist might employ. This is sophisticated, and it puts you in a position where saying no feels paternalistic and saying yes feels reckless. Now, yes, there is always the option of discharging from treatment. I have done an entire separate presentation on the mechanics and ethics of involuntary discharge from outpatient treatment, and I'd encourage you to review it because the process is far more complex than most clinicians appreciate. Discharging a patient who does not want to be discharged from outpatient care does carry clinical and legal risks that are comparable in some ways to involuntary discharge from an inpatient unit. It requires documentation. It requires a transition plan. It requires adequate notice. It requires that you do not abandon a patient in acute clinical need. The patient who is most dangerous to your practice is also, by definition, the patient most likely to turn a discharge into a formal complaint. But beyond these mechanisms, there is the philosophical problem with reaching for discharge too quickly. Every time we discharge a patient like this, we are in a very real sense failing. Not because we've done anything wrong, not because the patient's behavior is acceptable, but because the fundamental mission of any clinician is to help people who are suffering. And these patients are suffering. The personality pathology makes them difficult, sometimes impossible to work with, but it doesn't erase the anxiety, the depression, the substance dependence, the genuine misery that brought them to a psychiatrist's office in the first place. The control we actually have over the treatment process is much less than the general public imagines, much less, frankly, than medical schools suggest. In real world, the world of managed care, formularies, prior authorization battles, 15-minute medication checks, and patients who have read more about their condition on Reddit than you covered in your residency, the distance between ideal treatment and actual treatment is measured in miles, not inches. Patient preferences shape the treatment plan whether we like it or not. Insurance companies shape it whether we like it or not. Then patients, like the ones we've been discussing today, shape it in ways that are uniquely challenging because they combine genuine clinical need with a personality structure that turns every therapeutic interaction into a negotiation, every prescription into a battle, and every clinical boundary into a provocation. So, what do? You document meticulously. You set boundaries early, clearly, and in writing. You use peer consultation so that your clinical decisions have a second set of eyes on them. You resist the urge to deviate from standard practice, no matter how persuasively the patient argues. You monitor controlled substances with the rigor of an accountant, not a clinician, and you keep in the front of your mind all the times that your most important clinical tool in these encounters is not your prescription pad. It's your awareness that you are in the presence of something unusual, something that requires a fundamentally different posture than the therapeutic alliance you are trained to build. Because the therapeutic alliance with this particular patient is not the solution, it is the battlefield. And if you remember nothing else from this presentation, remember that idea.